Hey everybody. Sorry for the format for today's class and to not be able to be in person or to do a synchronous remote lecture, but I really appreciate the flexibility and understanding with regard to my own illness and that of my children. So I'll try my best to work through these slides as if it was a regular class, try to add as much as I can to what I think are the more important concepts and lessons from the reading for today and to prepare you for class on Wednesday. So today's class officially starts the fourth and final module of the course, where we're looking at more of comparative health policies across different regimes, countries, economies. And I think the book makes a strong case for why this type of analysis and perspective is needed, and that in general, what we've done so far is been partial equilibrium analysis, and from the perspective of individual economic agents, whether those be hospitals, insurance industries, physicians, healthcare providers, or individuals and consumers of healthcare, and understanding their demand for health capital and their risk aversion. And all of this is really helpful, and it allows us to understand how individual economic agents are going to respond to changes and incentives, but it doesn't allow us to do second and third order effects that we may be able to see in a general equilibrium approach, such as looking at the entire health system or a market level analysis that would allow us to get at maybe a better sense of what would be the total effects of completely overhauling the system and changing from something like a private healthcare system to something more like a Medicare for all or single payer type system. And I thought the best example that was given in the text was using this graph and saying, if we have a current level of demand for healthcare in our economy given by D1, and we have initial prices in the economy for healthcare, then we're going to observe an equilibrium level of healthcare consumed, X1, where that demand is going to intersect that price, and we get our familiar conditions of the marginal benefit being equal to the marginal cost, and that will determine our equilibrium level of initial healthcare expenditure. Now, if we're using a partial equilibrium analysis, looking at firm level behavior, and we want to predict what would be the total additional expenses associated with completely subsidizing healthcare and giving everybody free healthcare, then we're essentially just removing the price that consumers are facing from P1 and replacing that with zero. And so the total amount of healthcare consumed would be where D1 intersects the horizontal axis, where it intersects P equals zero. And so if the price that consumers face became zero, then the consumers of healthcare in that economy would consume X2 units of healthcare. And while they wouldn't be facing a price, the entire economy and society would still need to pay for physicians and hospitals to provide those services. And if we're assuming that that price that the society still has to pay is P1, then the total healthcare expenditure would be that per unit price, P1, multiplied by the total level of healthcare services consumed, X2. And so it would be this entire rectangle that with a height of P1 and a width of X2. And so the additional expenditures associated with, I'm sorry about that noise in the background. That is my youngest son who's crying in his crib. So if the initial expenditures were given by the per unit price of P1 multiplied by the equilibrium quantity healthcare consumed X1, and the new expenditures are from X1 to X2 at that same price, then the additional expenditures of completely subsidizing healthcare would just be this gray rectangle with width AB and height P1. Now, a general equilibrium analysis would say, wait a second, if we are completely subsidizing healthcare, then not only are the existing consumers going to increase their quantity demanded, have a movement along the demand curve from point A down to point X2, but we're going to be subsidizing healthcare and probably drawing new consumers into the healthcare economy. You know, this goes back to the very first week of class in the Better Health Economics book that that some consumers are so incredibly price sensitive that they won't even be part of the market if there are any prices. If we're completely subsidizing healthcare, then we're going to be giving a signal to producers that there's money to be made here. They're going to increase their quality of services. They're going to be competing for new customers based on quality, less on price. And if there's an increase in quality, then it's likely that the demand for healthcare is going to increase from D1 to D2. And so if we have an increase in the total demand for healthcare, then, and again, we're completely subsidizing the expense, then the total quantity of healthcare consumed is going to be where D2 is going to intersect the horizontal axis. And if there's a better quality of healthcare now, then the actual price that society has to pay increases from P1 to P2. And so the total healthcare expenditures now aren't just going to be this little rectangle from 0 P1 over to X2 and B, but it's going to be from 0 to P2 all the way over to C. And so when we allow for general equilibrium analysis, we can think of the second order effects that we're subsidizing healthcare, we're drawing new producers into the market, drawing new consumers into the market. They're going to be competing on quality, and we can get maybe a more accurate but also more comprehensive view of what the total new additional levels of expenditures would be from such a radical change, thinking about the general equilibrium rather than just the partial equilibrium. So if we're thinking of comparing entire healthcare systems, either for the sake of assessing why healthcare in the US seems to be less efficient and effective than healthcare in other countries, or thinking about what alternative models we could use if we want to improve healthcare within our country with a more radical change, then we need to be able to classify different healthcare systems. I think the textbook does a good job motivating the kind of Goldilocks approach that they use, where they first describe a one-dimensional classification system where they list a bunch of different criteria. For example, are the hospitals in your system public or are they private? And they point out that, look, this is way too simplistic. There's far more differences between healthcare systems than simply whether they differ along this one dimension. And so we need to look at more dimensions if we're going to have a more comprehensive way of classifying healthcare. So then they move on to a 5-dimensional system for analyzing healthcare organization. And they use prior work by one of the authors looking at 5 control knobs of changing how healthcare in a country is financed, how it's paid for, how it's organized, regulated behavior. And the problem with this is that it's too complex. There's way too many permutations within these 5 different variables. If each of them have 5 different levels, then the dimensionality is just going to explode, and we're not going to be able to really think of meaningful differences between different healthcare systems, because there's going to be so many different permutations that we could have. And so their Goldilocks solution is to have a simplistic yet a little more nuanced differentiation between healthcare systems along 2 dimensions, where they're going to compare the financing of healthcare services as either being private or public, and the provisioning of those services either being private or public. And this creates this 2x2 matrix where we can classify healthcare systems as either being a cash healthcare system if there's a public provisioning of services, and private financing of services, private if there's private provisioning of services and private financing of services. Then obviously you can see the other two options as well. And while this is still a little too simplistic, it is helpful. And so, simplistic because in reality, there's not this binary differentiation between public financing of healthcare and private financing. There's more of a spectrum ranging from 100% out-of-pocket payments that are needed to pay for healthcare services to slightly more organized and public system of everybody has private health insurance and you use those premiums to pay for your health insurance, and then the health insurance pays for your services, to a slightly more public version where we have a general tax revenue that's collected and is used to pay for healthcare services, to the even more public version of we have tax revenue that's going to be earmarked specifically for healthcare services. And you can think of an example of Medicare spending in the US, where if you work a job that's going to be taxed and they're collecting not only income tax on your wages, but also payroll taxes to pay for Social Security and Medicare, that tax revenue is earmarked specifically for the provisioning of healthcare services. And so even though in reality we've got more of the spectrum and not just this binary decision between public and private, it is a helpful way of kind of distilling down this the dimensionality into two simple ways that we can compare healthcare systems. And so I think the lack of a true binary between truly private and truly public is illustrated pretty well in this figure from the text in the 11.6, where we see that in these countries, there's very few that have 0% of their supply of healthcare services being public, as being 100% completely private supply. And while there are a few that are closer to that 100%, for example, the United Kingdom having almost exclusively all of its healthcare services provided by the public sector, for the most part, countries are going to fall somewhere between that completely privatized supply and completely socialized supply. Likewise, with financing, you'll notice that many of these countries are closer to the 100% of healthcare services being publicly financed than they are to the 0%, but still none of them are 100% publicly financed. And this imbalance here between the share of public financing for healthcare services being greater than 50% and less than 50% is due to the countries that are used in this graph, and that these are all mostly developed countries and economies, and that if we were to have the data for low-income countries, it's likely that they would exist in this top left-hand corner here, which would correspond with being a cash system for providing healthcare, where it's mostly public providers, state-owned hospitals, but most of the payments are coming out of pocket. And so obviously the only two countries which really appear in this table are going to be Mexico and Chile in this quadrant. We're going to think of a couple other examples that are mentioned in the text that would likely fall in this quadrant as well. And so two countries that seem to fit pretty well in that top left quadrant of having a public provision of healthcare services with a high level of private expenditures, private financing for the services are India and Vietnam. Single out these two countries because of the six or so that they mentioned. There's a lot of data regarding India's healthcare economy, and we're going to be learning more about healthcare in Vietnam on the very last day of class when one of your classmates gives a presentation about healthcare in this country. And so I think it's interesting to note, first of all, that these 10% and 12% of non-food income going towards out-of-pocket healthcare expenditures is a relatively high number. And we can contrast that with the second line here, which says that 75% of India's healthcare expenditure was out of pocket in 1999. So for $3 of every $4 that were spent on healthcare, we're not going through insurance. We're not coming from the state. These were just being paid directly out of people's pockets. And while this data is a little outdated, I think it's still interesting to consider. And I have not heard that it's necessarily changed that much, that substantially over this time, as evidenced by 10 years later in 2008, the statistic that only 5% of people in India had any form of health insurance. So this corresponds more so with what healthcare in the United States looked like in the 1910s, 1920s, before the New Deal, before we started having more health insurance. And it's obviously a risky way to provide health services within a country. And though there are some benefits, for example, there's no moral hazard. You're not incentivizing the overconsumption of healthcare by subsidizing it and telling people, well, even though your marginal benefit wouldn't outweigh the marginal cost of the full price, since we're effectively lowering the price, go ahead and just consume as much as you want until your willingness to pay is essentially zero. And we're not having that drag on the public financing of healthcare due to overconsumption of healthcare. It comes at the cost of healthcare not being accessible to those in poverty, there being no social safety net. It's hard to really think that a country is going to be better off if it has a slightly more efficient healthcare economy, but there's essentially no equity. And if you're born into pretty drastic circumstances, that if there is a relatively low-cost procedure that could save your life and you don't have the funds to be able to pay for it, then you're just going to be sentenced to misery and illness and death, and that doesn't quite seem fair either. So again, while there are some benefits, again, maybe something along the lines of it in a cash system, it perhaps could be more dynamic due to there being less regulation. There's less government oversight. There could be more entry and exit of firms, more kind of Darwinism, survival of the fittest within the healthcare providers, where only the most efficient, highest quality are able to succeed. In reality, though there's some theoretical arguments to be made that quality could be higher due to people more closely monitoring it because they're paying for it with their own dollars. In reality, the quality actually seems to be worse and there is no accessibility. So it's hard to make the argument that a cash system would be something that we would want to pursue. Now, private systems of healthcare are similar to cash systems in that the financing of healthcare is mostly coming from private sources, whether that is out-of-pocket expenditure or coming from private health insurance. The provisioning of the services in a private system is going to be more private and less public than in a cash system. Now, since private health insurance tends to dominate in these types of systems, and there's not a publicly provided method of funding healthcare services, you're more likely to have a multi-payer system than a single payer system under private financing. And just like a cash system, there are benefits and drawbacks with this approach. I think there's some pretty clear potential benefits of having a multi-payer system, where, like we have for the most part in the U.S. healthcare economy, we have our Blue Cross Blue Shield, our Aetna, our different health insurance companies. And because of this variety, you might be more likely to have all the heterogeneous preferences, all the different preferences of the 340 million people living in the United States be better satisfied if they have choice among health insurers that could offer lower premiums and less coverage to those who are who are less risk averse, and more comprehensive coverage to those who are more risk averse. And in addition to that, again, since we have more of a free market style where you have that survival of the fittest among the insurance providers, this may be more dynamic and lead to more innovation. So we've got more entry and exit in the health insurance market. And you also get more spillovers, perhaps due to competition, that if health insurance providers are competing with each other for more market share, then they're going to offer lower premiums. And under an ideal world, that's going to encourage their competitors to offer lower premiums to their customers. And we know that those assumptions are going to change if we have consolidation of healthcare providers, if we have market power either for the insurers or for the hospitals. But theoretically, there are some benefits associated with the multi-payer system. Now, the drawbacks associated with this type of system would be that you have unnecessary expenditure on overhead. That in a single payer system, you don't need to market your services. You don't need to spend money on advertising. You can simplify and have a standardized sense of doing the electronic records, filing taxes, that there's less administrative bloat, potentially less redundancy in staffing when you only have one company providing the services relative to multiple companies. And some other drawbacks mentioned earlier in the text include cost shifting. And so this is when, for example, Medicare may offer a lower reimbursement for a procedure. The hospital would say, okay, we were used to getting this amount of revenue total from Medicare and from our private insurance. Since now we're getting lower revenue from Medicare, we're going to have to raise the prices for our private plans. And in that sense, it's going to be, again, inefficient to have multiple providers. If there's patient selection, then the insurance firms that exist under the multi-payer system may not actually be competing in terms of price with each other and offering lower premiums. They may just be trying to attract the healthiest patients to their company, to their plans. And so they don't have an incentive to necessarily improve their efficiency or become a more streamlined, more efficient company. And lastly, the spillovers here, so this appears in both benefits and drawbacks, because when I hear spillovers, I think of those upstream and downstream spillovers that we mentioned in the last module, where if we know that a patient is going to be on private insurance when they're younger and Medicare when they're older, and there's some really expensive medication that is going to have a high upfront cost but isn't going to pay off till they're on Medicare, then there's less of an incentive for that private insurer to provide that service for the people while they're young, because they're going to be paying all the costs and not reaping any of the benefit when they get older. And so, again, this problem would be completely avoided if we had a single payer system where there's only one health insurance provider within the country. And so while we do have a multi-payer private healthcare system in the United States, we were really close to having a single payer healthcare system in the US due to the policy debates surrounding Obamacare, or the technical name, the Patient Protection and Affordable Care Act, or the ACA, that was signed into law in 2010. And given the importance of this legislation, given its impact on healthcare in the United States, I do want to spend more of this video, more of this class time today talking about it, and then we'll discuss it in even greater depth in class on Wednesday. And so this was this crowning policy achievement of the Obama administration. Healthcare reform had been progressive policy priority for decades in the United States, and finally in 2008, with the election of President Obama, they felt as if the Democrat Party felt as if they had the political capital, the votes to be able to pass a transformative change to the delivery of healthcare in the United States. And I think it's important to note that what exists today is not the policy that was enacted in 2010. It's not the policy that was dreamed of or campaigned on in 2008, but it's one that is still influential and still does have many benefits. And every time that politicians say they want to repeal and replace this, it doesn't really go anywhere because it is a overall pretty popular policy at this point in time. And so some of the features of the ACA were phased in. It wasn't fully implemented in 2010. Some of the features that were implemented in 2010 have been eliminated during the Trump administration. We'll talk about that in a little bit. And surprisingly, it survived judicial review by conservative Supreme Court for one of the more controversial aspects of the law, the individual mandate, that we'll talk about in a little bit. But I think it's important to note that this whole policy was seen as a compromise. It's based on the healthcare experiment in Massachusetts that was conducted by President Obama's 2012 political rival, Mitt Romney. And so this is really more of a conservative system of reform than the original preferred plan, which was a single payer, essentially Medicare for all. Now, the reason why we wound up with the Romney Care rather than the Medicare for all was because the Democrats preferred to pass this policy with as much political buy-in as possible, and so wanted to do so under normal legislative rules, in which case they needed 60 votes to get past a filibuster. It's hard to imagine anything that would be transformative today getting 60 votes in the Senate. I think if this policy had not been passed in 2010 and there was significant healthcare reform on the table today, the governing party would just suspend the filibuster, like we've seen happen for judicial appointments during the Obama administration, and then Supreme Court appointments during the Trump administration. And I think we're definitely going to see laws passed by suspending the filibuster in the next political administration, whoever that is. And but back in 2010, the Democrats and Obama needed every single one of these votes. And so some of the more conservative members of the Democratic caucus really pushed for this kind of Romney Care style healthcare system that would greatly expand the number of people with health insurance, but wouldn't go so far as to radically transform the healthcare system in the country to be a Medicare for all. So this was something that maybe we could have had they been more willing to suspend the filibuster for it, but based on the system that they had at the time, wanting more political buy-in, we wound up with a more conservative yet still transformative plan. And so on the syllabus, there's a link on Wednesday's class to all of the provisions of the Affordable Care Act. I'm going to try to simplify these in two ways. First, I want to talk about maybe 6 major provisions that are included, ones that we want to focus on. And then we'll further distill that, simplify that down to the three-legged stool, which is a metaphor that's been used for the past 15 years. And so the 6 major provisions that were included in the Affordable Care Act include guaranteed issue and modified community rating. And so the guaranteed issue means is essentially that we can't prohibit individuals from being able to buy health insurance simply because they have pre-existing conditions. In fact, the modified community rating goes hand in hand with this. Remember, community rating is different from experience rating. Experience rating is when you say you have all of these conditions, the actuarially fair value of your health insurance premiums is going to be much higher if you have more underlying health conditions, whereas community rating is going to say everybody within some geographical community of the same age is going to pay the same rate. And so the sick are going to necessarily be subsidized by the healthy under a community rating system. And so the Affordable Care Act said you have to provide health insurance to everybody regardless of whether or not they have pre-existing conditions, and you're not allowed to take those pre-existing conditions into account when you set their premium, since we're using the modified community rating system. Now, there are some factors that insurers are allowed to consider. For example, whether or not you use tobacco, whether you smoke, or I'm not sure how vaping isn't tobacco, so I don't know how they use that now. But again, this made health insurance affordable to a large portion of the population that was unjustly prohibited from getting health insurance just due to the nature of their birth and the conditions that they were born with. And a second major provision would be a minimum standard for insurance benefits that, going along with that first provision, you can't just say, all right, we're providing health insurance, it's got a $10,000 deductible, and then there's a 50% copay after that. That doesn't benefit anybody. And so there are certain standards that insurance plans have to meet to be able to qualify as providing health insurance within these communities. The individual mandate is probably the most controversial part of the Affordable Care Act. This is the requirement that every individual purchase health insurance. Otherwise, they have to pay a penalty. And so the thought here was that if when we go back to like the very first 2 weeks of class, due to the problem of adverse selection, if the healthiest people in the economy, in society, are going to be less likely to have they're going to have the lowest willingness to pay for health insurance and less likely to buy it, then, especially if we're using a community rating system, which is going to charge them a higher premium than their willingness to pay, we're going to require that they buy health insurance, which is going to resolve the adverse selection problem for the insurers. And we're going to require that they buy it by charging them a penalty that's going to essentially say, look, you're going to have to pay $500 a year, $600 a year anyway, so you may as well just spend that $600 on health insurance. Now, this was challenged, went to the Supreme Court, and the Supreme Court, even though it had a conservative majority, Chief Justice John Roberts sided with the liberals on the court and upheld this, saying, look, this is essentially just a tax. Even though the Obama administration at the time was defiantly saying the individual mandate is not a tax, this is how we're organizing our healthcare system, but it's not a tax. John Roberts said, no, this is a tax, and you're taxing people who don't buy health insurance, just like we tax people who do buy cigarettes with an excise tax. This is just a different form of a tax. So what that did was it upheld the individual mandate at that time, which is really important for reasons that we'll consider in a little bit. But it also paved the way for the Trump administration in 2017 to say, okay, if this is a tax, then we can effectively deal with this under budget reconciliation rather than under traditional legislative order. And we don't need 60 votes. We don't need to suspend a filibuster to get rid of the mandate. All we have to do is say we're going to lower that penalty all the way down to zero. So we're not technically getting rid of the individual mandate. We're not saying that people don't have to buy health insurance. We're just saying you have to buy health insurance. And if you don't buy health insurance, we're going to charge you a penalty, and that penalty is going to be zero. So effectively, while legislatively the individual mandate is still in place, effectively it isn't. And the concern was going to be that that would cause those really the healthier, younger people with the lower willingness to pay for insurance to drop out of the market. And that hasn't really been the experience so far, but we'll talk about that more so on Wednesday. Now, the last three major provisions aren't quite as exciting, but I think we still need to talk about them. One was another major provision was that the Affordable Care Act created health insurance exchanges or markets throughout the country and provided need-based subsidies to help people buy insurance on these exchanges. So remember going back to, I believe it was chapter 10 on private health insurance, in an employer-based insurance system, if you do not have an employer, then it's going to be hard for you to find health insurance. COBRA health insurance that you can get through an employer that you previously had is really expensive. And so the Affordable Care Act created these markets where health insurers could compete to try to attract people to buy health insurance who were not getting it through their employer or were getting really poor plans through their employer. And so this was another way to help encourage people to buy health insurance. And if your income was below a certain threshold, they would phase in subsidies to give you greater purchasing power to buy health insurance, to have more people be insured. Second to last year, the last two policies or provisions relate to Medicaid expansion and Medicare reimbursement. We're not going to go into the Medicare reimbursement policies. These are numerous, and I think they get really into the weeds. But it's important because of how much healthcare expenditure in the country comes from Medicare and what impact minor changes on Medicare policies would have on the overall healthcare expenditures in the country. The Medicaid expansion was another really controversial part of Obamacare, where they increased the ability, the threshold to qualify for Medicaid for health insurance for the impoverished, all the way up to 138% of the poverty line. However, the Supreme Court stated that states can reject expanding Medicaid eligibility, and even now there are a dozen states, at least a dozen I think, that do not or did not increase their Medicaid eligibility. And this is political grandstanding. The total cost to them as a state is relatively minimal. The federal government picks up most of the tab, and they do so along the lines of being principled and saying, look, we're not going to accept government handouts. This is government overreach. I don't necessarily know all the arguments that they would be proposing against this. But at the end of the day, you are voluntarily choosing not to provide health insurance to a significant portion of the residents in your state, and that seems like a not necessarily a wise or fair decision. And so again, not only could we consolidate the entire list of all the provisions and policies of the Affordable Care Act into those 6 major provisions on the previous slide, but we could further consolidate those 6 provisions into 3 classes of provisions that would form the 3-legged stool. And so this was a really common metaphor in the years after 2010 when there was a lot of political uproar regarding the individual mandate, saying that it violates personal freedom, that you can't require people to buy health insurance the same way you can't require people to eat their broccoli, using that example from the Better Health Economics book. But the argument in support of the individual mandate said, look, all these policies that are part of the Affordable Care Act form a 3-legged stool. And the point of a 3-legged stool is that if you take out one of these legs, the stool tips over. And so the 3 legs of the stool were the individual mandate, require everybody to buy insurance, guaranteed issue, require that health insurance is provided to everybody and charged in a way that is based on community rating and not experience rated, so that people can afford their health insurance. And then we have the tax subsidies to help people be able to further afford to be able to buy insurance. And so the argument was, if you kick out any of these legs, the other 2 won't stand. So if we remove the individual mandate, then because of the community rating and the guaranteed issue, a lot of young, healthy people are going to say, look, the price of buying insurance is so much more than what I would expect to pay at my age. And so while I know that there's some risk of getting sick, getting a chronic illness, getting in an accident, that risk is relatively low, and I would rather just pocket an extra $1,000 a year than spend it on insurance for something that I don't think I'm going to use. And I absolutely knew people who did this. I'm sure some of you do as well. So the argument would be that when that individual mandate was set to, that tax penalty associated with the individual mandate was set to 0, that all of the Affordable Care Act should have collapsed, but that's not what we've seen happen. So I think that's going to require some more analysis when we meet on Wednesday. So Wednesday's class is going to talk primarily about the evaluation of the Affordable Care Act. Now, the book notes that the textbook was written in, I think, 2014. The Affordable Care Act was implemented in 2010, and some of the policies were phased in, meaning not all the policies were in effect for all those 4 years. And so the literature at the time of publication of the textbook on the evaluation of the Affordable Care Act is relatively limited. So we're not going to rely on the textbook to evaluate the Affordable Care Act. We'll rely on some external readings. But 4 years before the Affordable Care Act was implemented, Romney Care was implemented in Massachusetts. And by the time the textbook was written in 2014, Romney Care had been in effect for 8 years, and that was enough time to evaluate the overall effects. And at that time, it seemed as if Romney Care in Massachusetts had been overall a pretty positive experience, that it improved population health. And in theory, both Romney Care and Obamacare, due to their similarities, could help fight job lock. And job lock is the theory that if your health insurance is tied to your employer, then you're going to be less likely to quit your job and look for a new job, or risk joblessness, wait longer to find the perfect job, because the longer you go without a job, the longer you go without health care. And so by severing that connection between the employer being the only way that you can get health insurance and getting your health insurance, that Romneycare and Obamacare should have created a greater incentive for people to stay unemployed longer, look for the perfect job for a longer period of time, and not necessarily just be tied to a job because it gives them health insurance. However, empirically, this effect appears to be minimal if it exists at all. And so this slide just says what I said in the previous slide, that we're going to talk more about the evaluation of the Affordable Care Act on Wednesday. And so to prepare for that, I'm going to ask that everybody read the ACA evaluation reading on the syllabus for Wednesday's class. You don't need to read all of the provisions of the Affordable Care Act. Those are there if you're curious, you want to learn more about it. But this evaluation article is kind of a meta-analysis or a systemic review where it's going to link to a lot of different articles touching on the different impacts of the Affordable Care Act over the first 10 years of its existence. And so we'll try to dive in specifically into some of these articles, talk about the general themes that have been found in the studies so far. So thanks for your patience with this video today. Thanks for your tolerance of this overall format, and I look forward to being back in the class with you all on Wednesday. So stay safe, stay healthy, and we'll see you then.